Hi, I'm Armando Engelsi, and my presentation will be on comparing the healthcare systems of Sweden and Germany. Before the 17th century in Sweden, local families provided healthcare. Around the 17th century, towns and cities employed physicians to provide care for the public. These provincial doctors were paid by a combination of state and local funds. In 1773, the national government took over the financing responsibility for these rural areas, while urban physicians were paid from local town funds. Since that time, healthcare in Sweden has been a largely public responsibility, which might explain why Sweden has less of a problem with government on healthcare than some countries. In 1862, Sweden established county councils, and healthcare was one of their principal duties. This was the beginning of Sweden's modern healthcare structure. Gradually, the county councils began to take more and more of the healthcare responsibilities from the central government. In 1946, Sweden adopted a universal healthcare system with the passing of the National Health Insurance Act. However, due to financial constraints and a desire to achieve more consensus among political parties, it was not implemented until 1955. In 1970, the Seven Crowns reform put the entirety of outpatient services under the responsibility of the county councils. 7 crowns was a fixed co-payment that patients paid for outpatient services. The county council was compensated directly by the National Health Insurance Authority for the remainder of the cost. This improved access to healthcare for lower-income groups, but it also made doctors salaried government employees and made it so they could no longer treat private patients seeking outpatient care in county council facilities. It also socialized private pharmacies. The Dagmar reform happened in 1984. Instead of health insurance reimbursing ambulatory care based on the number of patients, the capitation reimbursement scheme was put into place. This made county councils cost liable, but also led to expanding wait lists. It also took power away from the physicians because the county councils had the authority to approve which private practices should be reimbursed by national insurance, as well as the number of patients the practice could see a year. So from 83 to 92, county councils were fully responsible for the financing and provision of healthcare. Budgeting issues and technological advances increased costs that led to rationing and compromised care. So in the 1990s, Sweden began to open up healthcare to privatization in order to decrease costs. The reform in 1992 made long-term inpatient care for the elevated responsibility of the municipalities instead of the city councils. In that same year, the Patient Choice and Guarantee Act extended providers for patients outside of the country while guaranteeing that they be treated within 3 months of their diagnosis. This initially led to a 20% drop in the waiting list from 92 to 93, but the success was short-lived. In 94 and 95, care for the handicapped and the disabled was also transferred to the municipalities with the goal of improving services through integration between care and social services of the municipalities. The last 2 decades of Swedish healthcare have marked a number of reforms. Privatization has been allowed to be more prevalent in order to support the development of primary care. Privatization and competition in the pharmacy sector has also increased. In 2002, generic substitution for pharmaceuticals became mandatory. Germany's statutory health insurance can be traced back to the Middle Ages when guilds formed mutual aid societies. In the 19th century, voluntary mutual aid organizations continued this tradition in an occupation-specific manner. This patchwork of sickness funds was solidified in law in 1883 by Otto von Bismarck. Over the coming decades, statutory health insurance expanded to a larger percentage of the population. The fundamental structures of the social insurance system remained largely unchanged during the period of National Socialism. However, gradual restrictions were placed on Jewish doctors. This started with prohibiting them from treating patients covered by statutory health insurance in 1933, and then from treating non-Jewish patients in 1934. Eventually, Jewish physicians were banned from practicing medicine altogether in 1938, and this placed a great strain on the sickness funds. After World War II, Germany was split. The Soviets took a more authoritarian, centralized state-operated approach to healthcare, and the Allies attempted to support existing structures with the British administering healthcare affairs in a more centralized fashion, the French trying to limit centralization, and the Americans primarily pursuing ad hoc policies, a number of which were unsuccessful in achieving their goals. In 1949, the Christian Democratic Party won the first elections in West Germany with the support of employers. They restored the healthcare system that was in place at the end of the Weimar Republic before World War II. After the German reunification in 1990, East Germany's system of national health insurance was abandoned in favor of the Bismarck system of West Germany. Due to the sudden influx of the 17 million East German inhabitants into the statutory health insurance system, the following decades focused mostly on healthcare reforms to control expenditures. This is the Beveridge model for healthcare. The majority of financing comes from county councils, and the system is split to the national, regional, and local levels. Germany, of course, uses its namesake Bismarck model. Statutory health insurance is financed through the employer. Germany's health insurance is mostly split up between the statutory health insurance and the private health insurance, and these statutory health insurance funds are referred to as sickness funds. The Swedish government tends to control more of the healthcare system than that of the German government. County councils set the fees for primary care. Public and private healthcare compete to register patients instead of competing for profit. They're both publicly reimbursed. The county councils control the establishment of new private practices by regulating opening hours, clinical competencies, and other organizational aspects by regulating financial conditions for accreditation and payment. The German federal government exercises less control over the healthcare system, but the legal framework is set by the Federal Ministry of Health, and the Federal Joint Committee has wide-ranging regulatory power to determine what the sickness funds will cover and quality measures of providers. The decision-making powers are shared between states, the federal government, and the self-regulated organizations of payers and providers. Neither country has any gatekeeping, with the exception of a few specific programs by sickness funds in Germany. Also, neither country requires registration to visit a practice. In Sweden, you can register with any provider that's accredited by the local county councils, public or private. And patients normally pay an upfront fee for primary outpatient care, although it is often possible to pay later. In Germany, SHI physicians in ambulatory care bill a regional association according to a uniform fee schedule, and sickness funds pay the money to the association in the form of annual capitation. Both countries are required to supply after-hours care, and both have a national hotline and other resources to provide this. In Sweden, practices that are geographically near each other collaborate to provide after-hours care. There are no special pay arrangements for after-hours care, and the copays are the same for daytime. There are all-day staff to talk to and online resources for seeking care. 7 university hospitals and about 50 county hospitals offer 24-hour emergency care. In Germany, regulation for after-hours care varies regionally. This is organized by regional associations of accredited physicians in the statutory health system. Payment for after-hours ambulatory care is done with a fee schedule, with differences in the reimbursement amount among the statutory and private health insurance systems. The majority of hospitals in Sweden are public. Of the 7 university hospitals and approximately 70 hospitals in the county council level, 6 are private and 3 of those are not-for-profit. In Germany, public hospitals make up about half of all beds. Private not-for-profit hospitals make up about a third. Private for-profit beds make up about 1/6. Healthcare in Sweden is largely financed through income taxes by county councils. About 80% of healthcare spending was publicly financed in 2014, and Sweden spends about 11% of its GDP on healthcare. The majority of healthcare in Germany is funded by employer-provided sickness funds. In 2014, 74% of Germany's healthcare was publicly funded. This amounted to about 11.2% of Germany's GDP. Public health insurance in Sweden has no defined benefit package, while in Germany, SHI plans are required to have basic benefit package. In Sweden, these basic benefit packages can vary by county, but include things like public health and preventative services, primary care, inpatient and outpatient specialized care, emergency care, inpatient and outpatient prescription drugs, mental health care, rehabilitation services, disability support services, patient transport support services, home care and long-term care, including nursing home care and hospice care, dental care and optometry for children and young people, and adult dental care with limited subsidies. In Germany, the SHI mandatory benefit package includes things like preventative services, inpatient and outpatient hospital care, physician services, mental health care, dental care, optometry, physical therapy, prescription drugs, medical aid, rehabilitation, hospice and palliative care, and sick leave compensation. In Sweden, private insurance covered about 4% of the population in 2010. 82% of private insurance in Sweden is covered by employers. This is a non-deductible expense for employees and a non-taxable benefit for employees. One of the main uses for private health insurance in Sweden is to avoid waiting lines and to get quicker access to specialists. About 11% of the population was covered by private insurance in Germany in 2012. Private insurance is mandatory for certain groups in Germany, such as civil servants, and it is an alternative for the self-employed or those above a certain income threshold. Sweden and Germany are members of the European Union, so they are mandated to provide emergency medical care to all EU members, and healthcare in both countries is universal. In Sweden, children that are undocumented, seeking asylum, or permanent residents have the right to health care. Adults seeking asylum or undocumented have the right to receive care that cannot be deferred, such as maternal care. Germany has time restrictions for care for asylum seekers. Asylum seekers, both children and adults, are only eligible for primary care for acute conditions or for pain. Pregnant women or those that recently gave birth receive the same care as citizens. For prescription and appointment coverage, Swedes pay the full cost of prescriptions up to €122 annually. After that, subsidies gradually increase until the national cap of €244 annually. This is a fixed cost and not adjusted for income level. Children and the family have a separate out-of-pocket maximum at €244. There is also a €122 annual cap for health coverage visits, and patients under 20 are exempt from this fee. The fees are slightly less complicated in Germany. For prescriptions, Germans pay 10% of drug prices, which amounts to €5 to €10. They pay €10 each quarter to cover all physician visits, and they must receive a referral to see a new doctor or specialist, or pay a €10 copay. As I mentioned before, GDP for healthcare spending is about 11% for each country. Spending per capita in Sweden amounts to about $5,306, and about $5,119 in Germany. Patient out-of-pocket spending in Sweden is a little bit higher at $787, and $664 in Germany. Prescription spending in Sweden is much lower at $486 and $741 in Germany. Hospital spending per discharge is much higher in Sweden at about $12,393 and $5,900 in Germany. Life expectancy for women in Sweden and Germany are roughly equal to 83.2 years and 83.1 years. For men, the average life expectancy in Sweden is 1 year longer than in Germany at 79.1 years and 78.1 years. Infant mortality per 1,000 births is slightly lower in Sweden than in Germany at 2.49 and 3.4. Sweden doesn't have much more issues with access than Germany. When surveyed, 19% of Swedes reported waiting 2 months or more for an appointment with a specialist, compared to Germany only reporting 3%. 12% of Swedes reported waiting 4 months or more for elective surgery, while Germany reported 0%. Access barriers due to cost were fairly close at 8% for Sweden and 7% in Germany. 26% of Swedes said the doctor or healthcare professional discussed their main goals and priorities in caring for their condition. 67% of Germans said the same. 30% of Swedes said their doctor or healthcare professional discussed treatment options with them, including side effects. Germany had twice as many at 60%. 32% of Swedes said they had experienced a coordination problem over the last 2 years, while Germany only reported 19%. 52% of Swedes said they had gaps in hospital discharge planning in the past 2 years, while only 28% of Germans said the same. When asked if their primary care practice routinely received data comparing performance to other practices, 55% of Swedes said yes, and only 29% of Germans. If the provider routinely received and reviewed clinical outcomes data, 79% of Swedes said yes, and only 44% of Germans. If the primary care practice routinely received and reviewed patient satisfaction and experience data, 88% of Swedes said yes, and only 25% of Germans. For overall satisfaction with the healthcare system, 31% of Swedes said it works well and only minor changes are needed, compared to 60% of Germany. 58% of Swedes said fundamental changes were needed, compared to 37% for Germany. 8% of Swedes and 3% of Germans said this system needs to be completely rebuilt. It seems that even though the Swedes have a greater propensity to gather feedback on their patient visits, Germany seems to be more satisfied with their healthcare system overall. This concludes my presentation. Thank you.